Well, let's talk about the direct composite restorations after the adhesion and isolation protocols. There are 8 different steps for placing class 2 composite restorations within adequate interdental anatomy. The first one is rubber dam isolation, and then pre-wedging if you want. And we need to evaluate the space between the adjacent tooth and interdental clearance, selection of matrix band, then positioning of matrix band, and after that, stabilization of the matrix band, and at the final step, composite layering. We have already talked about the rubber dam isolation, and rubber dam isolation have lots of different advantages for direct or indirect restoration or any kind of adhesive restorations. Firstly, they creates contrast and you can see that clearly, and they increases the visibility, and also they increases the adhesive quality, and by the way, they decrease the leakage of the saliva or any bleeding. Then pre-wedging is the other step, and they separate the teeth before the application, tucking in a wedge between the adjacent teeth. They making easier to separate the teeth, and they avoids the burr irritation of gingiva, especially very deep cavities. They are very protective materials, and they directly avoid the irritation of gingiva, and also they protects the teething of rubber dam sheets, and finally they compensates for the thickness of matrix band. And especially for deep cavities, pre-wedging is very effective method, and by using this method you can see the cavity lines, cavity borders clearly, and I mostly apply this method especially for deep cavities restoration. The other one is interproximal clearance. Actually, before we start any kind of adhesive restoration, first of all, we must clean all the surface of the tooth to have a good quality of adhesion. For example, if there's a bacterial plaque, bacterial accumulation on the buccal surface of the tooth that are planning to be restored, we we cannot have a good quality of adhesion, and we must clean the buccal surface of teeth, and we must clean all around the teeth by using air abrasion, and I most prefer 29 micron aluminum oxide particles to clean the tooth surface, and they are making my job easier. And here we clean the buccal surface of tooth before the adhesive restoration, and that's the final before the restoration. And the other step is interproximal clearance, and volumetric harmony of the interproximal area is essential for a functional and aesthetic class 2 composite restoration. Therefore, the interproximal space available should be evaluated prior to placement of the matrix band. And if there's an over counterproximal surface of the adjacent tooth, they should be corrected, as this can result in an inverted anatomy and in the formation of a deficient contact area. And here, if we need a proximal contour of adjacent tooth, will be adjusted using the abrasive discs in the middle and occlusal third. Here there was a over-contoured adjacent tooth restoration, and if we directly try to make a restoration here, it is impossible to have a good anatomy, a good anatomical proximal surface. So we must clean and we must arrange the adjacent tooth contact surface by using the composite discs, and interproximal clearance allows passive positioning of the matrix band. And because the forcing the matrix band in an interproximal space without interproximal clearance can result in deformation of the matrix band and imagination of the matrix and inversion of the emergence profile. So it is very important before we start the layering, before starting the matrix adaptation. And the other one is space evaluation. Space evaluation is the other important thing because we are selecting our matrix systems depends on the space evaluation, and we are diagnosing the and we are deciding the treatment plan depends on the space evaluation. If there's an angulated teeth on the neighborhood, we may apply another filling, we may apply some arrangement on the surface of the adjacent tooth. So it is the other important step. For example, the patient may visit you by the complaint of there's a food infection on the cervical area, and before you start that kind of restoration, you must think about or you must have a plan that what kind of metric system you should use on that kind of restorations. And after the rubber dam isolation, there was a very big gap between the premolar and molar area, and the main problem was the anatomy of the first molar tooth, the mesial anatomy of the first molar tooth, and also other problem was there was some gingival recession on the proximal surface, and it might be related to food impaction. And here we must change the anatomy of the proximal area. After cleaning the after cleaning the caries on the proximal surfaces, you should compare the different surfaces. For example, on the distal side, the space is a bit less when you compare with the mesial side. And on the mesial side, we need a very large contoured matrix bands. And when you check it from the buccal surface, when you compare with the distal side and mesial side, the mesial side have a large space when you compare with the distal one. And you can use some gates for some periodontal gates and some other special gates to evaluate the gaps and to evaluate the spaces. And then you should select the matrix band, what kind of matrix band you want to use. There are different matrix bands. We have already talked about that, but before the restoration, we should decide which one is better. Because to be honest, I cannot say there is just one matrix system in the market. I cannot say there is just one ideal matrix band in the market. And we are deciding the matrix systems depends on the condition of the cavity. And you know the Toffel-Maher matrices and circumferential matrices are very effective matrix band, especially at the former time we were using them for all kind of restorations. But then there some problem occurred, took place because of the anatomy of the matrix systems. And by using that kind of matrix bands, it's a bit difficult to create the anatomical proximal surface. To be honest, they are very effective for the deep margin elevation, and sometimes you can use them for the MOD cavities, especially for the children, for the pediatric patients, they are very easier it's very easier to stabilize them because of their system, but their proximal anatomy is insufficient. And contour-sectional metal matrix are widely considered to be the most effective matrices for placement of direct composite restorations involving the proximal surface. For the restoration of a single box, only one thickness of the metal material is encountered instead of two, making contact generation easier. The sectional matrix should have a correct curve profile and making it possible to create a correct emergence profile in the cervical occlusal direction from bottom to top. To select the correct matrix band, you must be aware of its maximum curve. The matrix bands are available in different heights with and without subgingival extension. And for example, a 6.5 millimeter high sectional matrix band has a maximum curvature of plus minus 0.5. Here is the 6.5 millimeter high sectional matrix band, and the curvature is almost 0.5 millimeter. An increased proximal curvature of the matrix band is required when the distance between the cervical cavity margin and the neighbor tooth increases. This is observed when the cervical cavity margin comes in a more apical position. And if there's a very deep cavity, you may need to use that kind of larger contoured matrix systems. And hard stainless steel sectional saddle matrices and perforated matrices have maximum curvature 0.7 millimeter here and here. The maximum curvature starts more cervically, making it easier to reach the deeper margins. And here you can see they are very useful for the deep margin elevation. And biofit matrix bands have the highest maximum curvature, 0.9 millimeter. These matrix bands are contoured plastic or mylar sectional matrices available in two thickness. Transparent matrices might allow for better light transmission and allegedly more efficient polymerization of the underlying resin composite. The biofit matrix bands have a larger buccolingual wrap, and the anatomy of the matrix bands directly wrap the tooth that are planning to be restored. And they can be used in cavities that are more open in a buccolingual direction. In addition, the matrix features of curved occlusal embrasure, which, if the matrix is well positioned, shortens the finishing time of the occlusal embrasures with burrs or discs. And here you are seeing the same photo again. The mesial side of the tooth have larger gap when you compare with the distal side, and we must use a larger contoured matrix band here, like a biofit bioclear matrix band, like a bioclear matrix band. And on the distal side, we need a small contoured, a short contoured matrix bands because the distance, the space is very narrow when you compare with the mesial side. And on the distal side, I prefer the sectional matrix band, and on the mesial side, I prefer the biofit matrix band. And when you check it on the buccal, from the buccal surface, buccal aspect, the anatomy directly try to touch to the neighbor tooth on the center, and you can create a good anatomical proximal surfaces by using that kind of special matrix band. And the matrix band should be positioned into the interproximal space without any friction and should have the correct height. If the matrix band is too high, there is a risk that the marginal ridge and the occlusal surface will be modeled too high. Consequently, considerable time will be needed to grind the occlusion. And if the matrix band is too short, there is a risk that the marginal ridge will overlap the marginal ridge of the adjacent tooth, or even worse, will bond to an existing composite restoration of the adjacent tooth. To be honest, it's really nightmare to bond the other existing composite restoration, because it takes very long time to separate the restorations after finishing the restoration. And in case a biofit matrix is used, the occlusal embrasures is included in the matrix band. If the correct height of the matrix band is selected, the dentist has good control if the occlusal embrasures is in a correct position. And we can use the stabilization rings. We need the stabilization matrix band can be obtained using a wedge, a separation ring, Teflon tape, and a flowable blockout resins. The different possibilities and indications will be shown now. And here you are seeing the wedge. And sometimes when I use the circumferential matrix bands, I directly use the we must use the wedge to stabilize the dam, or Toffel-Mayer system. We always must use the wedge, especially for the proximal restoration. But sometimes we can use the separation ring, and separation clamp will create interdental separation and stabilize the matrix band. And they can directly separate, especially when you are doing the when you are planning to restore both the adjacent tooth. You need to separate the teeth, and a large variability in separation clamp is available on the dental market. Most rings are angled to allow stagability in any combination for MOD and multiple tooth restorations. But when it comes to placement of two rings simultaneously, both mesially and distally result in a separation effect in the opposite direction, and therefore diminish their effect at the applied contact area. So here, firstly, you are placing the mesial ring, and then you are placing the distal ring, and they both try to separate the tooth, but they are separating the tooth at the same position, so they decrease their effect. So I mostly prefer to place the ring systems at different times. And also you can use the Polydentia's sectional rings, sectional stabilizers. And the other option is blockout resins, and I mostly prefer it, especially for the clamped tooth, and especially for the second molar, distal side of the second molar. They are very nightmare to prepare, to make a restoration, to have a isolated area. And here we can use the blackout resins or flowable resins, and they can be applied in between matrix band and adjacent to, or you can stabilize it by using the rubber dam clamp in order to help in stabilize the matrix band, especially in the situations where a separation clamp is not used. And for that tooth, for that restoration, I applied the BioClear matrix band on the distal side, and I stabilized it by using the blockout resins. And on the mesial side, I used the Paludens ring stabilization rings. And then after creating the proximal surfaces, then I directly finished the restoration by layering. And also we can use other auxiliary elements such as Teflon tape, especially for very different anatomically shaped tooth. Here there's a first premolar tooth, then there's a very deep concavity on the bottom of the cavity on the mesial side. And when I tried to place a matrix band and weights, it was impossible to place it. It was impossible to have a good marginal adaptation. Then we can prefer matrix in matrix systems. And I placed another matrix band. You can use the sectional matrix band, and also you can use a bit of TOEFL matrix bands by cutting them. And after that, you are tucking in the space between two matrix bands, you are tucking a Teflon tape, a piece of Teflon tape. Then you can directly adapt the matrix band that you placed in the inside, inward of the system. And then you can elevate the margin by using that system, by using that method. And Teflon tape is a plastic non-sticky material and resistant to high temperatures. And during the last decade, the classical plumber Teflon tape has also been used in the dental office. And to be honest, for that kind of restorations, they are very useful. And when you compare with retraction cords, they are non-sticky materials and very easy to remove it after any kind of resin restorations. And the other method is again by using Teflon tape. I call it Teflon tape wedging technique. And sometimes if there isn't any adjacent tooth, it is impossible to stabilize your sectional matrix band. And especially if you placed a if you placed a rubber dam clamp on that tooth, it's almost impossible to stabilize your matrix systems. And here again, we can use a Teflon tape to stabilize the matrix band. And otherwise, it's almost impossible to keep it stabilized, keep your matrix band stabilized. And also we can use that method for the buccal or palatal side, because the palatal side of the tooth, especially for the molar tooths, they have very different, very curved palatal anatomy, especially for deep restorations. And when you try to place a BioClear, even if you are using BioClear matrix band, you still will have a gap between matrix band and tooth. And here again, we can use the Teflon tape wedging technique to adapt the matrix band, and it's the palatal aspect. Just I'm tucking it in the gingival pocket. There are different colors in the market, but they mostly similar. Just I can say that the yellow one is a bit thicker when you compare with the other colors. And after correct positioning and stabilization of the matrix band, the adhesive system is applied and the composite layering takes place. Let's talk about the placing of the composites. Before posterior or anterior restorations, before any kind of resin restorations, any aesthetic restorations, we should evaluate the anatomy and we should know the anatomy and morphology of the tooth. And for the lower teeth and for the upper teeth, the anatomy looks and the anatomy maybe show some differences, especially for the molar tooth. So before we start, we must know the anatomy of tooth, and then we should start the layering technique. And if the patient doesn't have any crowding or any orthodontic problem in their mouth, the center line of the fissures mostly placed on the center of the tooth, and the adjacent tooth mostly have the same fissure line on the from second molar to the mesial side of the first molar. And then we must connect the marginal layers. We must connect the layers from buccal to palatal side. We should connect them on the center of the tooth. And then we should emerge the marginal ridges at the center of the tooth. And the other one is the proximal morphology, and the contact point should be placed at the 0.5 millimeter below from the marginal ridge. Otherwise, if you create the contact point below the normal anatomy, the patient may have some food impaction here, especially when they are consuming the fibrous meals like a meat. They may have some complaints about the food impaction. And if we place the contact point very above when you compare with the normal anatomy, that time the patient may feel food impaction on the cervical area. And also, if you make a over contour on the occlusal surface, when you try to make some occlusal arrangement, you may directly open a diastema, open a gap between the tooth and the adjacent tooth. So that time you may need to renew your restoration. And if the patient visit you again because of some complaints like food impaction. And let's look at the proximal morphology, how I create the proximal morphology for class 2 cavities. And after rubber dam isolation, I cleaned all the cave area, all the caries. Then I placed the rubber dam matrix band. Then I placed the matrix band, BioClear matrix band. For any kind of sectional matrix band, we must use ring systems to separate the tooth. Otherwise, because of the thickness of the matrix band, after we finish the restoration, if we didn't use a ring system, ring separators, because of the thickness of the matrix system, we may create some gaps between the adjacent teeth. Then it's very it's a nightmare for me to have a gap between the teeth after finishing the restoration. And then when you check the buccal touching point of the tooth, of the adjacent tooth and the matrix band, it's almost placed at 0.5 below from the marginal ridge. Then I finished the restoration by layering, and the important point is here. You must have that kind of touching point on the buccal, on the proximal surface. Otherwise, if you place it below, you may encounter, or the patient may encounter, with a food infection on the occlusal area. And the other option, if you place it above, after occlusal arrangement, you may create some gaps, or the patient may feel food infection on the cervical area. And after that, I want to mention about the deep margin elevation. Sometimes before direct or indirect restoration, especially very deep cavities, we may need surgical steps to see the margins, to see the cavity margins clearly. So for the deep margin elevation concept, you may try, or you may restore the tooth. You may elevate the margin without any surgical operation by using some extra isolation and separation methods. And let's talk about how I manage that kind of tooth in my daily practice without surgical steps. After I cleaned the surfaces, the cavity borders were under the below the gingiva. They were placed at subgingival area. And when I tried to place the matrix band, it was impossible to isolate and to seal the tooth, to grab the anatomy of the tooth. But by using some methods, again, Teflon tape wedging, we can isolate that kind of restorations. I'm just tucking in to gingival pocket a piece of Teflon tape by using the instrument. And then after that, I can start my elevation steps. For in that patient, we prefer the indirect restoration. But after that, you can also use the direct restoration. Depends on your diagnosis. And especially for deep cavities, I mostly prefer high filler content flowable composites, like from GC Injectable, Universal, or Tokuyama has some high viscosity injectable composites, and Shofu has the similar one, and Voco has the similar highly filler content injectable composites. And I mostly prefer highly filler content injectable composites for deep margin elevation. Otherwise, it is impossible. It is difficult. Not impossible, but it's very difficult to stabilize your rubber dam matrix. Like here, I placed my matrix system here, and I tucked a Teflon tape into the gingival pocket. And if I try to apply layering technique here, I will make some movement on the matrix band. And for this reason, I mostly prefer the flowable composites are effective for me to seal that area. And after that, I elevate the margin, and then I covered the pulp chamber by using the same flowable composites. And then we made a indirect restoration. And also we can use this technique for the direct restoration. There was a very deep cavity on the distal side of first molar. And I prefer the perforated matrix band, but when you are planning to apply deep margin elevation, you shouldn't forget that it is impossible to finalize your proximal surface by using just one matrix band. After that, I removed the perforated matrix band, and I placed another matrix band here to continue my restoration. And let's look at how can we manage that kind of palatal fractures, palatal cusp fractures. And it's similar with the deep margin elevation, but if we are planning to apply a pre-endo build-up, because for the endodontic treatments, we must have isolated area without any leakage. And if we are planning to make a two-step, two session, it is easier to make a pre-endo build-up at the first session. And after placing the rubber dam clamp, I applied and I applied an adhesive on the palatal surface by using hand instrument and also brush. At this step, after creating the palatal wall, for the second visit, I don't need to use any extra retraction for the palatal side, because the elevating the palatal area will allow to place the matrix band easily on the second session. And also, if you are planning to make indirect restorations, they are also deep marginal elevations as well. So the deep marginal elevations are the basis, or they are forming the basis of pre-endo build-up. And then we applied the last step, we applied the last layer, and after that you can finish your endodontic restoration. And also sometimes you may encounter with the extreme cases, and you may use plastic wedges for the isolation, for the retraction of the rubber dam, but still you may need some piece of sectional matrix band to have a good stabilization, good sealing. At this step, I prefer the Cooper matrix band because they are bendable and shapeable when you compare with the other stainless steel metals. For that kind of restorations, I mostly prefer the copper matrix band. Then I elevate the margins, and it is ready for the endodontical retreatment. Here is the step. And also we can use for some other methods. And let's talk about the layering and direct restorations and other auxiliary elements for the direct restorations. Before I start the layering technique, I want to mention about the fiber rip-on placement, especially for cracked lines or cracked tooth or cracked cusps underneath the or cracked area, cracked line underneath the cusps. We may use fiber rip-on materials to keep them stabilized, and also we must reduce the cusps. If we see that kind of crack line, we should try to leave the crack line. But if we cannot do that, then we may use some fiber materials, and you can use there's some couple of brands in the market, but the well-known is the Ripon fibers, and you can use the Ripon fibers there to keep the crack line at the same level. They are protecting the separation of the crack line or progression of the crack line. Then we place the fiber ribbon on the dentinal surface. You must be careful when you are placing that kind of fiber materials. You shouldn't extend the dentin enamel junction. Otherwise, you may encounter with some leakage problem here. So you should keep the fiber materials in the dentinal area, and you should leave it far from the dentin enamel junction. You can use it for the direct or indirect restorations. And the final of the restoration, and also especially for the amalgam mercury restoration, I mostly encounter that kind of crack lines, and I mostly prefer to convert my diagnose indication to indirect restoration, because when you compare with that kind of crack lines, it is better to apply indirect restorations or cusp covering or direct cusp coverage for that kind of tooth. Otherwise, you may encounter with the severe problem like a fracturing and then the extraction at the final. And sometimes you may encounter with the similar problem underneath the amalgam and mercury restorations, and there is a crack line on the dentin surface. And again, I placed a rip-on fiber. Before rip-on fibers, you must keep them in the resins, its own resins or non-acidic resins. And before application, you must apply a bit of composite underneath the fiber rip-on. Then before curing, you are placing the rip-on fiber, then you are covering it by using the flowable composites. And here is the similar problem, and let's look at how I manage the rip-on fibers on the dentinal surface. After etching the enamel surface, it is kind of immediate dentin sealing, but by using the fiber rip-ons, it's a fiber reinforced composite, and I am placing the wetted rip-on fibers, and I try to stabilize it as much as closer as to the dentinal surface. And before curing, I need to shape it, and then after curing, I must cover around the fiber rip-on to avoid the leakage, because the fibers may have absorbed the water, so you must cover the fibers. You must cover around the fibers. And for the end, let's talk about how can we finalize our last step, how can we finalize the restoration. There are different materials in the market, and we have already talked about the injectable composites, and they are highly filler content composites, and the filler ratio should have above the 65%. And also the company's prescription, you should find on the company's user manual, you should find the indication of the class 2 cavities. For example, if the company doesn't propose if the company doesn't advise that you can use that composite for the class 2 restorations, you shouldn't use that. But some companies for the genial injectable universal and Tokuyama high viscosity flowable composites, they are advising you that you can use their restorations for class 2 cavities as well. And let's look at how we can manage the class 2 cavities by using just injectable composites. After placing the sectional matrix band system, then I etch the enamel surface. I only etch the enamel surface to protect the postoperative sensitivity. Then I applied the adhesion, and after creating the proximal wall, I am covering the bottom and the base of the tooth by using the fiber reinforced Averix composite, and then I placed the injectable composite for each cusp separately, and then the polishing procedures. And they are also very useful for the narrow cavities, and you can control the amount of the composite resin. And you may finalize that kind of small cavities by using these kind of highly filler content injectable composites. And the other technique is stamp technique. Before you start the restoration, you are getting the impression of the occlusion surface by using the resin blockhouse resins or some silicone index, and then after curing you are removing it from the surface, and it's the anatomy. They directly copy the anatomy of the occlusal surface, and then after placing the composite on the occlusal surface, you are applying a bit of Teflon tape, then you are pushing with a high force your index, and then you should clean the remaining resins before the curing, and you can use your brush to adapt the composites and the curing. The main problem is for that method is the C factor, configuration factor, because the composite is trying to bond more than 3 or 4 walls at the same time. So the composites have the shrinkage problem, polymerization shrinkage problem, and for that technique you may encounter with some micro leakage because of the polymerization shrinkage. And we can also use that method on the class 2 cavities. Before we start restoration, we can get the impression of the occlusal surface. We should copy the occlusal surface. After cleaning the composites, after cleaning the caries, then we can create the proximal walls, and after that we should seal the dentin surface. For that method, if you are planning to use that method, you should use the composites on the dentin and enamel separately. For example, you should firstly cover the dentin surface, then you can apply that method. After covering the dentin surface, I placed a Teflon tape and I placed my copy on the occlusion surface. That method, to be honest, I cannot say it's very effective method, because you are placing the you are creating the proximal walls by the help of your matrix band, and sometimes there may be some irregular areas and incompatible areas because of the early touching point between the proximal area and your occlusal guide, your occlusal impression. So you can make it for the class 2 cavities as well, but I prefer the layering technique, and because to deal with the configuration factor. For example, for the class 1 cavities or for the deep cavities, we may use the caries dye, and then after cleaning the infected dentin surface, then I etch the surface, I etch the enamel surface, and I fill the bulk fill. I fill the dentin by using the bulk fill flowable composite, because you know the bulk fill composite have more transparency, and their the light transmission is better than when you compare with the conventional flowable composites. And sometimes you may apply the bulk fill composite for 4 or 5 millimeter in depth, and then I start to apply incremental technique. Firstly, I made the mesial buccal cusp, then I made the mesial lingual cusp, and after that I create the distopalatal cusp, and I finalize the restoration by placing the composite on the disto buccal side. And for the class 2 cavities, my order is firstly adapting matrix band, then creating the proximal wall with the condensable composites, and after that covering the dentin surface by the help of flowable composite, and finalize my restoration by the help of conventional condensable composites. And it is the class 2 cavities, Imodium cavities, and firstly I placed two sectional ring at the same time, and I created the proximal walls. There was two different indirect restoration planning for the first premolar and for the first molar. So in that position you may use two different separation ring at the same time, because you will create the proximal wall by using the indirect restoration after you finalize that one. So it doesn't matter even if you create a small gaps between the two. And then I create the proximal wall, and I sealed the dentin surface by the help of flowable composites, bulk fill flowable composite like SDR or 3M's Filtex bulk fill composites. There are lots of different brands in the market. To be honest, it is very difficult for me to say you the brand of the composite that because there is no ideal, there is no perfect composites in the market, because all the companies may claim that their composites are the best one, but to be honest, it's completely related to your daily practice. And some people may think about some brands are better than the other ones, but the other people may think about the opposite. So I just want to say the type of the composite here. You can use the bulk fill composites at the bottom of the cavity to seal the dentin surface. Then by using the conventional composites, you may finalize your restoration by layering. After creating the buccal surface, then I place the composite on the palatal area, and after that I made the proximal composites. I placed the proximal composites and finished the polishing procedures. And let's look at how I manage the class 1 and buckle restoration. There was a deep caries on the occlusal surface, and also there was a caries on the buccal surface of tooth. I am cleaning the surface, and sometimes, especially when I'm at the very deep area, I mostly prefer my slow speed handpiece without water. And at the last step, I clean the surface by using 29 micron aluminum oxide particles. And after that, I'm etching the enamel surface. Especially for deep cavities, I mostly prefer selective etching technique, which includes etching of the only enamel surface. Then I'm applying the adhesive layer and polymerization, and I am covering the deep area by using the bulk fill flowable composites. At this step, the important thing is before curing, you must adapt the composite on the wall of the tooth, on the dentinal wall of the tooth. And you shouldn't exceed the dentinal enamel junction when you are using that kind of bulk fill composites because they don't have an indication for the finalizing the restoration. So you should finish your bulk fill composite at the dentin level. And after that, I'm creating the buccal and occlusal area at the same time. Firstly, I place the composite on the mesial side of the tooth. Then now I'm placing the composite on the distal side. Before curing, it is very important to clean the excessive material. Otherwise, you may spend very long time on the polishing procedure. These are my essential hand instruments for composite polishing. And that one is very useful from Hue Freddy 3D Shaper. And this thin tip composite brush are very useful as well. And they are especially effective for creating the occlusal fissures. And after that, the final step, it's not a mandatory, it's totally related to create some contrast area. You may use some makeup composites, but they are very dangerous because some people may show reaction about the why there's some caries on my tooth. So when you are using that kind of restoration, that kind of colors, you should inform your patients before they look at the mirror. And at the final step, you can use the glycerin gel to elevate the to avoid the oxygen inhibition layer. The glycerin gels are very effective for the final step because the composites are very weak. They have weakness at the first 24 hours for the colorful things, for the hard meals like nuts. So the effect of the glycerin is to remove the oxygen inhibition layer. And the other option is the, again, layering technique. Firstly, I placed the flowable composite. There was a small amount of crack line. Then I covered the fiber report by using fiber reinforced composite. And then at the final step, after covering the dentin surface till the dentin enamel junction, I directly start to place the conventional composite. Here I am applying the composite with a very small amount at the final step. And what about for the root canal treated restorations? Before application of the matrix band, we sometimes also use the small brush tips to reach the very deep and small areas on the bonding procedure. Firstly, I am closing the entrance of the root canal orifice. Here, before polishing, before curing, we may need to bend or position our matrix band. The problem is in that kind of situations, sometimes when you bend your matrix band, you may create very large, very deep proximal cervical embrasures. So here it is why we need to decide the matrix system that we are planning to use before the restoration. And after I created the dentin layer, I started to apply the enamel composites. Or you can directly use the body shade composites. For posterior composite restorations, I mostly prefer the body shade composites. Sometimes I want to sometimes I want to use some dentin enamel or some makeup colors like occlusal fissure colors for the occlusal fissure dyes. And I'm using my thin tip, small tip brush to create the fissures. And after that, I use the makeup colors by the help of endodontic file. And here it is the proximal anatomy. And before we finalize the restoration, we must have a contact point, contact touching point anatomy. So it is very important point to have a good anatomical contact. And also, Paul, I want to mention about the pulp capping on one case. There was some caries and a mercury filling on the distal side. And after cleaning the surface, after cleaning the caries, the pulp exposure, the pulp exposure occurred, and after that, I placed a 2.5% sodium hypochlorite embedded cotton in the cavity to stop the bleeding. And after that, I placed a Neo MTA to the surface, and after that, I cleaned the MTA remainings from the dentinal area to have a good adhesion, because after MTA it is very difficult to have good adhesion because the MTA doesn't like the adhesive procedures. So I mostly prefer glass ionomer sealants or sometimes Terracotta is very effective to cover the MTA. And after that, I placed my matrix band on the proximal surface by the help of resin blockout resins or gingival barriers. It depends on you. And by the help of BioClear matrix band, they are wrapping tooth, and their anatomy is very effective for that method. And after that, I placed a ring system on the mesial side, and I made the proximal walls by the help of highly filler content injectable composites. For that kind of restorations, when you don't have very strong stabilization, uh, it is better to use highly filler content injectable composites, not to harm, not to move your matrix band. And it is the final of the restoration and the final X-ray of the restoration. I mostly take an X-ray, especially for the class 2 cavities, to check the irregular areas. And when you look at the distal side, the anatomy of the BioClear matrix band looks very amazing and very curved anatomy. It has very curved and anatomical surface. And let's talk about the polymerization and polishing procedures.